So good afternoon, and thank you for joining us for the third session of the 2024 Older Adults and Opioids webinar series hosted by the Finger Lakes Geriatric Education Center. We are a HRSA-funded geriatric workforce enhancement program at the University of Rochester in Rochester, New York, and our co-sponsor is the Western New York Rural Area Health Education Center, which is also a HRSA-funded education center. So this year is the 5th year we've been hosting these educational sessions, so thank you so much for your support and for tuning in. My name is Laura Robinson, and I am the program coordinator for the Finger Lakes Geriatric Education Center. And my co-host is Christine Chappell. She is the administrative coordinator at the Western New York Rural AHEC. So just a couple housekeeping items before we begin. We are using Zoom meeting today, and there are just two important buttons on your Zoom toolbar I want to point out. Please use the chat button to type in hello and introduce yourself with a name, job title, agency, and or credentials, especially if your Zoom name does not match your real name. So if you want to get your continuing education credits, I need to know what your real name is. So please check your name and tell us who you are. We have people from at least 14 states and 2 countries joining us today. Next, please keep your microphone muted. We are in meeting format. If you suddenly unmute, me or Christine will mute you. So now just to go to the slides. We are pleased to offer continuing education credits for this session. We are offering CME, social work, physical therapy, occupational therapy, and mental health practitioner credits. None of our speakers or the one speaker or planning committee have any financial disclosures or conflicts of interest. Following this session, we will email you instructions on how to claim your credits following this session. Please allow up to 30 days to receive your credits. We have to gather your attendance information, upload it into the system. So it does take a little time. We do not email you transcripts or certificates. You have to log into the system or take a survey to get the OTPT or mental health practitioner credits, but that will be in the email following this session. There has been no commercial funding used to support this activity. And if you have not already registered for the next webinar in the series, Dr. Tim Holohan will be joining us next month to talk about medical marijuana in older adults. And the QR code is there on the screen, or I can email it to you following the session. So now I'm going to take down my slides and ask Dr. Desai to share his screen and his slides while I introduce him. So our speaker today is Dr. Desai. He is a geriatric psychiatrist, medical director of Idaho Memory and Aging Center, and an adjunct associate professor in the Department of Psychiatry at the University of Washington School of Medicine. He is the co-author, along with his mentor, Dr. George Grossberg, who is a national and international leader in geriatric psychiatry, of the book Psychiatric Consultation in Long-Term Care, a Guide for Healthcare Professionals. He was the guest editor for the Clinics of Geriatric Medicine special issue, why can I not talk today, entitled Healthy Brain Aging, Evidence-Based Methods to Preserve Brain Function and Prevent Dementia. His practice focuses on helping patients with mental health challenges and dementia and helping their family members live the best life possible in all care settings: home, long-term care, hospital, and hospice. He has been in practice for over 24 years. So we're very honored to have such a dedicated and experienced practitioner with us today. So I will now turn the program over to Dr. Desai.
Thank you, Laura. Delighted and honored to be here. Your thumbs up means people can hear me. And
yes, we can hear you, we can see you, we can see the slides.
Excellent, thank you. So as you heard, I'm in Boise, so University of Washington has an Idaho track. But I also work in other states. So regarding financial disclosures, as Laura mentioned, I've mentioned this book in one of the references, Psychiatric Consultation in Long-Term Care. And then I'm deep into mindfulness, meditation. Me and my wife, she's a psychologist. So we've written this book that I recommend as a resource to help patients manage pain and so forth. Other than that, I have no other financial relationships with any drug companies or big pharma or anything else. So learning objectives, number one would be to describe at least one key strategy to reduce opioid use disorder in older adults, so reduce the prevalence. Then second objective is to describe practical strategies for early accurate diagnosis of opioid use disorder in older adults in primary care. And third is, to discuss evidence-based pharmacological and non-pharmacological interventions to successfully manage opioid use disorder in older adults. This is my perspective on aging. Aging is a privilege. Growing old is not a disease to be cured or defeated, but a privilege, tremendous privilege to be humbled by, to be grateful for. A privilege withheld from most of our ancestors and so many of our brothers and sisters. Let's become worthy of becoming old by falling in love easily, holding our heart gently, holding our fears lightly, and forgiving continuously. So there is a lot of anti-ageism that our older adults face, so we need to help with that. And then again, we all know about the stigma of addictions and opioid use disorder. So regarding prevention, this quote by Bishop Desmond Tutu I find useful. There comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they are falling in. So again, we need to double, triple our efforts in prevention of opioid use disorder besides treatment. Strategy without tactics is the slowest route to victory, and tactics without strategy is the noise before defeat by Sun Tzu. So again, if we are to focus on prevention of opioid use disorder, we'll need strategies and tactics. So Dr. Ashwin Patkar, believe it or not, he was in the same medical college in India as I was. He's brilliant. He's an addiction specialist. And in this paper, he talked about three key things to prevent opioid overdose. So remember, when we talk about prevention, we need to prevent overdose, and also we need to go upstream and prevent opioid use disorder. So to prevent overdose, we need to enhance access to virtual treatment. So I do a lot of collaborative care psychiatry, and many a times that might be the only thing available to a lot of individuals in rural settings. So we need to enhance access, expand access of opioid use treatment. An example would be in many prison population, they do not have access to buprenorphine or Suboxone, combination of buprenorphine and naloxone. So we need to address that, and in many other settings, obviously, and to increase education of naloxone. Now, this education is not only just in individuals who have addictions, but in family members, in community people, in our police workforce. And as you know, this opioid crisis is reaching younger populations. So one could make a case that even parents of children and school teachers need to know about naloxone. And just to clarify, naloxone is the treatment given when you suspect opioid use disorder. You give it right away, and then it can prevent death and other complications due to opioid use disorder. Other prevention strategies specifically for opioid overdose. Now, remember, all this applies not just to older adults, but to all age groups, is to develop early identification of opioid problems. So there is a second category called opioid misuse that happens before you develop a full-blown opioid use disorder or opioid addiction disorder. So we need to catch them in that misuse stage, very early stage. And all this ideally should be happening in the primary care. Unfortunately, primary care is just so overburdened that we need to first focus on getting the primary care, all the resources that they need, including more time and less number of patients, so that they can do this important work of screening for all addictions, including opioid misuse, opioid use, brief intervention where you just talk to them about, why this is serious, and then refer to treatment where they can get comprehensive treatment. And then there is integrated dual diagnosis treatment that has been researched, where a lot of our individuals with opioid use disorder, including older adults, have dual diagnosis. They have other addictions. They have other mental health conditions like schizophrenia, bipolar disorder, post-traumatic stress disorder. So we need to have very specific programs towards that. Again, we need to improve education on opioid prescribing. Basically, it means that we need to dramatically reduce the use of long-term opioid therapy or giving opioids for chronic pain. We need to reduce that. Obviously, I'm not talking about palliative care settings or cancer settings, but most of the opioid use for chronic pain is in other settings and for other conditions. And then again, if we don't simultaneously identify and treat comorbid psychiatric conditions like severe depression, chronic severe anxiety, trauma, then we are not going to get the outcomes we want, including reducing opioid overdose. So I'm big into rational deprescribing. That's like a staple skill and intervention in geriatric medicine practice, geriatric psychiatry. And we need to do this quite routinely in all older adults, but especially older adults with opioid use disorder. So let me share a case. 68-year-old female reports, quote, severe, unquote, pain, past back surgery, chronic back pain. She also reports severe insomnia. Everything is severe. So all this is causing her severe anxiety. Her anxiety is, quote, terrible, end of quote. She has been to emergency department several times, at least one hospital admission for opioid overdose, history of methamphetamine use. She states that she doesn't use it. The urine drug screen was positive because her daughter was smoking meth and she inhaled it. They live in the same house. She's trying to get the daughter to leave. Past history of marijuana use to manage pain. She's also on ropinirole, Requip, used in her case for restless leg syndrome. She's on 2 milligrams. It's quite a high dose. And trazodone, 150 milligrams at bedtime for insomnia. She reports it doesn't help. She's tried olanzapine, 7.5 milligrams at bedtime for insomnia. It doesn't work. History of using many benzodiazepines and opioids, and she uses it up before the refill date. She reports that the only thing that helps her anxiety and sleep is high-dose lorazepam. And until she gets that, she's willing to continue Ambien, Zolpidem for insomnia, although it doesn't help. She has tried Vicodin, has not helped. Suboxone has not helped. Tramadol did not help. She's tried Seroquel for insomnia, did not help. So this case, I got involved through collaborative geriatric psychiatric care with a geriatrician in Colorado, providing PACE program for all-inclusive care of the elderly. So I joined by video. The geriatrician is present in person with the patient. And then obviously I can talk to the patient. We talked back and forth. She told me all this. And at the end, I told her, I think the best thing I can do is to put you back on Suboxone, combination of buprenorphine and naloxone. And she said, no, it has not worked. And again, she wanted all these other medicines. I said, I hear you, I'm sorry. She was quite upset with me. She felt that I was unempathic. The geriatrician over there was getting nervous because she thought that probably we were. She hadn't seen a lot of opioid use disorder and addictions. So when I told her that we'll do more harm than good. The geriatrician felt more comfortable not giving opioids or benzodiazepines or all kinds of other treatments. The patient left in anger, but then came back. She has successfully had the daughter leave. In the PACE program, they have a social worker, so she was able to help her out. And now she's on Suboxone and doing much better. She still doesn't think she has addiction problems. She doesn't want to go to any self-help support groups, but she's willing to do individual counseling for stress, anxiety management, and we are doing very close follow-up. So that's a case where we also tapered and discontinued her ropinirole. We use gabapentin for her restless leg syndrome. We also tapered and discontinued her trazodone. There are a lot of risks of using multiple sedating medicines along with opioids, including buprenorphine, because you increase the risk of overdose complications. So hopefully she'll continue. We'll come back to this case for other situations too, but I think we did something to reduce her risk of future overdose. And again, another prevention of opioid use disorder is minimize or avoid long-term opioid treatment for chronic pain. And again, in this case, she was exposed to opioids prescribed when she had her back surgery and chronic back pain. And if we had provided better care, we meaning our system, medical system, and prevented her from getting opioids for more than a month, that would have been a good thing. And maybe we would have provided her developing opioid use disorder. So the strategy is avoid long-term opioid therapy, and the tactic is collaborative geriatric care via telemedicine. And it can be any collaborative care where the experts are available to primary care via telemedicine to hold their hands and help them do the right thing and improve their sort of capacity to assess pain and anxiety and insomnia, and also stay firm and not given to a lot of the prescriptions because the pressure from the patients will be very high. The second tactic that I've seen in research setting is peer-led pain management program. I know a lot of peer-led interventions that are now becoming routine in psychiatric care, especially for schizophrenia, PTSD, bipolar disorder, and it's good to see that in pain also. And Dr. Grossberg and I have written a chapter in this textbook of geriatric medicine where we clarify what should be done if we don't provide opioids for moderate to severe chronic pain, where we go through these steps. And again, we can talk about more details, but the key thing is to realize that most of our patients do not get comprehensive multidisciplinary treatment that they need for adequate chronic pain management. And again, our systems do not allow this to be easily accessed and available, but this is where the money is: physical therapy, cognitive behavior therapy for pain, exercise therapy, and mindfulness-based treatments. And we can again talk more about this. So I'm going to switch gears from prevention, our first objective, to the second one. What do we do for early accurate diagnosis? So again, in our paper, which is available for you guys to read in more detail, Screening and Management of Opioid Use Disorders in Older Adults in Primary Care, we talk about using DSM-5 criteria. It's an excellent group of criteria, and it's really not hard to give this diagnosis. It's hard more because the patient doesn't want that label. We are reluctant to give that label. We are not sure, but all they require is 2 out of 9 criteria, and that's very easy to reach. If any patient is, say, using opioids more than they should, or they're using it for things not intended, like they're not using it for pain management, but they're using it because they are stressed out, they can't sleep due to stress, to feel euphoria, then you meet one criteria. And even if you don't meet any other criteria, that itself, you would be in the category of opioid misuse. And then all you have to do is meet one more where this kind of behavior, habit is causing problems in your relationships, at work. It's causing you to have health problems. You've had falls. In the case that I mentioned, obviously, she had overdose. She went to the hospital. So there is no question that she has opioid use disorder. But sometimes it's not easy. So it's good to have validated tools to use. Again, in primary care, they're so time stretched that it's going to be hard to get them to use that. We have to just figure out alternative ways to support primary care. And then obviously, we need to look at prescription drug monitoring program. In the older adults, the best information you'll get is from family members, friends, staff in long-term care, even neighbors. So again, we need to ask them and involve them as much as is possible. Many a times, the presentation in older adults will be very different than younger people, where they will come to the emergency department with falls. And if you address the falls but don't address the primary problem, which is opioid misuse or opioid use disorder, then we are setting that person up for failure and even worse problems than falls. So again, in the emergency department, we need to provide education, but I don't think sometimes education is as much of a problem as, again, they are also overworked and time strapped. But we need to come up with systems where any older adult who comes to the emergency department with behavioral emergencies or medical emergencies, we try and routinely screen for all addictions, not just opioid, alcohol and cannabis, maybe even more common. And then again, we need to look at the red flags. So if they have frequent refills, if they're saying this dose is not working, I increase my dose, they do it on their own, multiple emergency department visits, multiple prescribers, these are all red flags that would indicate they have a serious problem. Sometimes, the meds are really stolen, but again, have a high index of suspicion that they've used it up. In older adults, believe it or not, they share medications, including opioids. If a spouse is on opioids and the other spouse has pain, they'll say, "Oh, why don't you take my pill and see if it helps you?" So keep that in mind as a behavior, and then sometimes that can go upwards, where they are taking their family members' opioids. Again, mood changes, irritability, aggressive behaviors could be a sign of either too much opioids or more likely opioid withdrawal. And then again, not taking as prescribed. So let me stop here and switch gears again. So in early diagnosis, it's important to not misdiagnose opioid use disorder also. So sometimes patients who need opioids develop opioid-induced hyperalgesia, which means that now you give opioids and the pain increases, but if you don't realize that it is opioid-induced hyperalgesia. So opioids have messed up with our brain networks and neurotransmitters and are having a paradoxical effect where they are now causing pain. They are inducing hyperalgesia, which means that a mild pain will be experienced as severe pain so when you realize that, you will think, oh, the opioids are not working because of opioid tolerance. They have lost the effect. So you would actually increase the opioid. But if they have opioid-induced hyperalgesia, you will cause more harm. So anytime when the person says that I'm in a lot of pain and the medicines are not working, stop and ask yourself, is this opioid-induced hyperalgesia? Because the treatment would be actually to reduce the opioids, not increase it, or perhaps even taper and try a different route. So again, if they are in withdrawal, they will have a lot of pain, but opioid withdrawal will have other opioid withdrawal symptoms. And that way you can accurately identify compared to opioid-induced hyperalgesia. And then again, if they are saying, I'm in severe pain, but actually you think they are just using it to manage stress and anxiety, then that's opioid use disorder or opioid addiction, which is different from opioid-induced hyperalgesia. So now that we've talked about early diagnosis, let me talk a little bit about treatment. So again, we have non-drug interventions or psychosocial interventions and pharmacological interventions. Psychosocial interventions, a lot of you already know. I have this article also available for you. Dr. Grossberg and I wrote this substance use disorder in post-acute and long-term care. So a lot of the psychosocial interventions are similar for addictions. The big first step is education of just about everyone, because even now there is stigma. Even now we don't realize that it is a true neurological illness, and we need to come to terms with that. Then motivational interviewing, like in this case that I talked about, she was really not interested in acknowledging that she has serious addiction problems, but we are hoping that over time she's able to individual therapy, counseling. There is a lot of trauma in all addictions, but especially in older adults with opioid use disorder. So we need to address that, because otherwise that would increase the risk of relapse, opioid overdose, and more serious complications. We are having harder and harder time finding individual therapists, but studies have shown that actually group therapy would not only reach more people, but might be even more effective, especially for many psychiatric disorders, including addictions, and even more important for opioid use disorder in older adults. So to me, I would put a lot of money and resources trying to get that. We know about mutual aid support groups, and contingency management is more important for methamphetamine stimulant use in terms of research support. But the patient I told you, the 68-year-old, she had methamphetamine use disorder as well as opioid use disorder. So she could benefit from contingency management, where we provide some incentives for her not to use that are of value to her. Moving on from psychosocial, spiritual interventions, non-drug interventions to pharmacological interventions. So many experts, many clinicians who work in the world of opioid use disorder, including me, strongly feel that in many cases, pharmacological interventions might suffice, like in the case that I mentioned. As long as she's, I believe, so it's my belief, I could be wrong, as long as she's on buprenorphine, I think we've done a lot of good, even if ideally she should be on all kinds of other non-pharmacological interventions. So going back to pharmacological interventions, we talked about naloxone. It is the key drug for overdose management. We need to teach ourselves, our family members, patients, how to use, what formulation is available, and make it really accessible. So the cost is a big barrier. But we need to also be aware of other drugs besides buprenorphine and naloxone that are important. So I've used clonidine. It's an older drug, hypertension treatment drug. We don't use it in older adults, so it gets tricky. But in younger people, I've used a lot of clonidine for manage opioid withdrawal symptoms, along with other drugs. But now, just for all of us to know, FDA has approved a drug called lofexidine for opioid withdrawal management. So it's not like a dramatic reduction in symptoms, but it does have modest benefits in terms of reducing anxiety, improving sleep, reducing tachycardia, and elevated blood pressure. So it has its place in opioid withdrawal. Then a lot of my patients, especially older adults, don't want to be on opioids at all, and they have fantastic support system. So in that, and that's another thing in older adults is I've seen, at least the cases I see, a lot of support from family, friends. It's just that it took some bad events for them to confront their addiction. So they don't want to go on opioids at all, including buprenorphine. So naltrexone is an excellent option. It's approved for opioid use disorder by the FDA. It's an opioid antagonist. You take it as a pill, and it's also available as a monthly injection. By the way, it's also approved by the FDA for alcohol use disorder. So we need to just keep that in mind. And I've seen, enough good results to say that we should keep that as an option. And then I have a lot of patients on methadone. They've been on methadone for a long time, and then they start having health problems, and I get involved, and I explain to the primary care and family and friends that opioid use disorder is a dangerous thing, and we need to either keep methadone or switch to buprenorphine, but we cannot take our eyes off opioid use disorder just because they have been doing well on methadone for a long time. So this is really the combination that has revolutionized treatment of opioid use disorder. I explained that opioid use disorder is no different from any chronic neurological condition or medical condition. And so we need to give treatment for a long time, not just for a few months. And the patients and family members need to understand that buprenorphine is not as dangerous as the full agonists like the morphine or the oxy or the hydrocodone or the fentanyl that they were addicted to. So the benefit of buprenorphine is that it's a partial agonist to the opioid mu receptors in the brain. So one good thing is that the euphoria will be less. So that's a good thing. Otherwise, they will start craving. And then again, there is a ceiling effect. So even if you overdose on buprenorphine, unless you are on any other sedating drugs, there's a good chance that you won't have overdose complications. But again, ideally, we should give both psychosocial approaches, including buprenorphine naloxone treatment. But if I had to pick one, I would pick buprenorphine naloxone over psychosocial interventions. Now, remember, that's in general. For a specific case, psychosocial interventions might be the right first-line treatment. And again, please do not hesitate to keep these interventions for a long time. And again, if you talk about effectiveness and outcomes, then naltrexone doesn't have as great an outcome, meaning that a lot of people go on naltrexone, and unfortunately, they'll relapse. They'll stop taking naltrexone and go back to opioids from the streets or prescriptions. So definitely buprenorphine and methadone have better outcomes. In older adults, buprenorphine is safer than methadone. Methadone has its own risks that are more than buprenorphine. Again, methadone is a full agonist, and it also has some cardiac risks and other risks. But it's a very effective drug. I've had a lot of my patients whose lives are radically altered for the better. They got back their life, in fact, because of methadone. Lot of, even believe it or not, even this day and age, a lot of physicians, primary care physicians, have a hard time wrapping around the idea that you're giving somebody opioid to treat an opioid addiction. So there's a lot of education we need to do in the physician, nurse practitioner, physician assistant, primary care community, and even specialists, believe it or not, they just can't wrap their mind around it. It's a complex concept of harm reduction, but to me, it's established. as an effective treatment, very effective. And now in the older adults, you start having memory problems. They're living alone. So then it gets tricky to give opioids. So then maybe naltrexone would be a better option. So when we talked about co-occurring disorders, we dual diagnosis, we always talk about opioid addiction with, say, schizophrenia, bipolar. But we need to also realize that there are a lot of older adults who have like serious neurological issues, like starting of dementia, and have opioid use disorder. So it's a whole different beast. Again, a plug for collaborative geriatric psychiatry care in such complex cases can dramatically improve outcomes. And again, if you're giving naltrexone, then they really need to go through the full opioid withdrawal process. And opioid withdrawal is so hard that without a lot of help and support, the person will relapse. So we need to just keep that in mind. Again, in older adults, engaging family members, spouse, partners, children, friends, their spiritual community, church, anyone, all these people will have much bigger impact on older adults in terms of them acknowledging the problem and not using the drug of abuse or addiction anymore. And again, shared decision making is essential. Like in this case, she did not want any addiction treatment, and we respected that. We disagreed, and then there is so much ageism bias, that limits resources in this population that we need to actively advocate for them. We just assume that they don't have capacity, or that they're totally disabled, or that because of the physical health problems, their brain is not functioning intelligently, and it's not true at all. Some of these research advances in the future, we'll see more benefits, like the fentanyl crisis is very high, and we need to figure out very accurately that the current problem of overdose, say, in the emergency department is because of fentanyl overdose. So we need good tests to check that. This study of mindfulness-oriented recovery enhancement was a phenomenal study, randomized control trial in veterans, where you teach them about mindfulness and being aware of the cravings and how to manage it, and savoring small successes, and how that reduced the use of PRN, use of opioids. So again, we need to train people in these interventions, team members, social workers would be phenomenal in this intervention as leading that. And then virtual reality is coming even to older adults, long-term care population, dementia population. So I would keep an eye for that. Some of you may know Dr. Atul Gawande. He's written superb books. He's a surgeon, and he wrote this book when he was helping his own father through his father's end-of-life challenges. And he saw how complex care of the older adults was, and palliative care. So we are caught in a transitional phase. However miserable the old system has been, we are all experts at it. We know the dance moves. With this new way in which we together try to figure out how to face mortality and preserve the fiber of a meaningful life with its loyalties and individuality, we are plodding novices. We are going through a societal learning curve, one person at a time. Now you can extrapolate that to all older adults with opioid use disorder. The old system is miserable, and yet we are experts at giving opioids for chronic pain. We know the dance moves of that approach, but that's not the way to go forward. The new way is very different, where you provide multidisciplinary, multi-pronged interventions for chronic pain management. And we are figuring it out how to do it we need obviously government and the big healthcare systems to support it, so that the older adults with addictions, opioid use disorder, can come back to a meaningful life. And perhaps we'll have to learn this one person at a time, hoping it's not that slow. Again, sometimes we don't try and spend time, or we don't have time. I think the system should give us time so that we can try and understand the person, talk to them about what their experience is about opioid use disorder. What is their perspective? How did this even happen? So it's important to getting to know the person. In this first meeting, I was trying to get to know her, and she was so focused on addiction. But in the future meetings, that would be a top priority. Sometimes they have artistic skills and all kinds of other strengths that are dormant, and we can sort of reignite them. Again, kindness rather than judgments. Friendship, as the Surgeon General has said, there's just so much loneliness. People ask me, what's the cause of opioid use disorder? I say LSD. I say, what? Loneliness, social isolation, and disconnection. So there you have it. They need friends. We all need friends to live better. And optimism, again, it's so easy to go into the doom and gloom. So we need to ourselves be optimistic and sort of almost like infect others with optimism. Again, experts have talked about human rights-based approach. So we need to include them in participation. I hope somebody is there in today's this session, who's a patient, who can respond to all the things I've said and what areas I have made errors. I want to correct them. I want them to participate with us in educating and changing everything possible in the area of opioid use disorder. Accountability, yeah, our institutions and our government need to really give us resources, and we need to hold them accountable. Non-discrimination, again, all the resources are going in the area where people already have a lot of resources. So we need to address that factor. Empowerment, where we give them power back, individuals with addiction, especially older adults, and legality, in terms of decision-making capacities and so forth. And again, we need to really be careful. And I joke that I'm the word police in many of my teams, where people know, and I do it nicely, not in a mean way, where I say, all right, let's not use the word addict, and so forth. So a person with opioid use disorder is much more than just their addictions. And again, we are just always hearing the message of doom and gloom, So we need to really protect ourselves and focus on more evidence-based message, share positive stories, and then go back, in psychiatry, we've been talking about this biopsychosocial spiritual approach forever. And it took, I don't know, 1,000,000 years. I'm just kidding again. Anyway, so now at least it's established, I feel, that all cases, all right, diabetes, migraine, cancer, opioid use disorder, needs a biopsychosocial spiritual approach, where we just don't focus on treating symptoms of opioid use disorder. We also focus on preventing the distress and suffering, and also not just focus on removing disability, but also improving their well-being. We just don't want them to be unhappy. We want them to be joyful in life. And again, we're not just focused on having them live longer. Once you rescue them from overdose, we want to enhance their quality of day-to-day life. as I mentioned, I'm deep into mindfulness. So it's important sometimes for all of us to remind ourselves that the patient is there and we are very important for them. So let's just not keep looking at the computer and type. Let's try and look at them and connect with them, be present. And again, offering hope is really, really important. And we can tell them that we have now a lot of research to tell us how to help you, you know. So there is reason to be hopeful. We are addressing some of this today, right? There's a lot of poor health literacy, especially in addictions and opioid use disorder. So we need to address that asymmetry. Then there is a lot of asymmetry in power, where the patient wants treatment and they don't have appointments for the next 2 months. It's like, are you kidding me? And they have no power over that. You know, they can't sort of hold the feet of the systems to fire. You know, and everything is so profit centered that needs to really be addressed head on. And fast medicine, you know, we just do an 8-minute visit, 10-minute visit. That's not going to work. And again, we need to go back to slow medicine, biopsychosocial approach, really focus on quality training, high quality. And then again, you know, everybody works in their silos. We shouldn't do that. We need to work as a team. Nurse, social worker, they can really run the show. They're all superb and brilliant. They just need to be empowered and given resources. So my own personal opinions now that we need to be interdisciplinary and doesn't have to be in person. Telemedicine can help. Biopsychosocial approach, actively address social disparities, and Friends of Opioid Use Disorder program, you know. So I'll stop here and see if you guys have any questions. I have some handouts that I'll share also, if we have time.
We definitely have time. Thank you so much, Dr. Desai. That was wonderful. And I think within the chat, there are many comments just about bringing in the reminder that we're working with people and how to have that compassion. So at this time, I invite people to please put some questions for Dr. Desai in the chat. While we wait for people to type, I had one question for you. I love that you brought up stigma, especially ageism. That's an area that I'm interested in. But how do you address that stigma of ageism or bias towards or stigma towards people who have opioid use disorder? How do you address that with other healthcare practitioners without it coming across as offensive?
Yeah, correct. Well, you know, so ageism, you know, we ourselves have to acknowledge that we sometimes slip, right? So I sometimes might say something that is ageist, and then through mindfulness, I catch myself. And we are each other's bells. So in mindfulness, meditation, Buddhism, you know, there's a bell, so that tells you, all right, slow down. And so we need to remind each other gently. And again, if we have good relationships, then the other person won't be offended because they know that we value them and we are not judging them in terms of you're a bad person. It's just that this is a bad habit and it's going to take time, but it also requires being aware and acknowledging it. And same thing with addictions. You know, I talk to the team members and tell them head up front that I'm the word police, so just be ready. But over time, they know me, you know, and in some cases, even in the first meeting, you know, I'm able to connect and they know that I mean well, but we need to do it, you know, and qualify that I'm struggling with this too. I've been doing this. I've been myself using these words, you know, are you clean? Are you dirty? Right? We should need to stop using that word, you know.
Right.
If the family members use it, we need to tell them, all right, I need to stop you here. just so that you know my perspective, that you know that your husband is much more than an addict. I know you're going through all this stress, so it's hard for you to see anything but addict, you know.
So language is very important. And if we can do it gently
Yes, yes.
and consistently,
Correct, correct.
we can spread that message.
Yeah, yeah.
Okay. So let me just check the chat for any questions. I
can
don't
share some
see any.
resources if
That would be
what
very
you need.
welcome.
So, oh, this is the case. Let me share. All right. So this is the one document I'll send you, Laura, and you can send to everyone.
Wonderful.
So
Thank you.
avoiding opioids and treating chronic non-cancer pain effectively. So the first page is, all the case evidence as to why we should not use opioids for chronic pain. So in some cases, patients want to listen. Most of this is for providers. When they read this, they realize that all the research so far, like the CDC guidelines that came out, everybody says insufficient evidence, serious harm, insufficient evidence, serious harm. Look at the improvement in the first 3 months is by 1 point in a scale of 0 to 10, and after 3 months is 0.5. So reduce the pain, let's say the pain is 9. So you're giving a drug that is dangerous, and all you're getting is a pain from 9 to 8.5. Is it really, are we doing more good than harm? I would say no, And some studies have shown even that is not happening. So there's only one study in randomized control trial in individuals 50 years and older for chronic back pain, hip and knee pain, and opioids did not do better than placebo. So again, we have another systematic review, and opioids did not do better than placebo for chronic pain. And definitely for diabetic neuropathy, we have experts telling us don't give opioids. And by the way, tramadol is an opioid, and we can talk more about that. One of the documents in this is tramadont, just for you to know. But there are a lot of other tools in this that might benefit you. So let me stop here and ask our attendees whether they agree with me in terms of so many of the things I've talked about. Some of that is my opinion,
Mhm.
and because some people might come out and say that, I'm not living in a real world, that opioids are needed for chronic pain management, and I'm much more forceful against it. But I can tell you, I'm in clinical practice. I have an academic hat, but that's not my main gig. It's a side gig. I'm seeing patients every day in outpatient setting, in long-term care settings, home visits, PACE programs, and hospital settings. So I think it's doable.
I'm going to stop recording, hoping that folks want to maybe unmute and share some responses.
Yeah,
Okay.
yeah. Success stories. Let's end. We have a few minutes. If we can share success stories, that would be great.